The next disorder is probably something we've all felt like we've experienced at one time or another, and with a female prevalence of 30% and a male prevalence of 19%, there's a good chance that many of us probably have. To qualify as a disorder, the anxiety must be out of proportion with the stimulus, so a significant amount of anxiety over something that should be provoking a fair amount of anxiety, such as an important test, does not qualify as a disorder. The term anxiety disorder is actually an umbrella term that encompasses panic disorder, phobias, OCD, PTSD, and generalized anxiety disorder. Panic disorder is another classic boards topic. To have panic disorder, patients need to have recurrent episodes exhibiting at least 4 of the following 13 clinical signs and symptoms: palpitations, paresthesia, abdominal distress, nausea, intense fear of dying or losing control, lightheadedness, chest pain, chills, choking, disconnectedness, sweating, shaking, or shortness of breath. It can be remembered with the memory aid PANIX. Imagine an executive who was giving a presentation in front of his business partners, and he began having chest pain associated with chills, sweating, and palpitations. It'd be difficult to distinguish this from a run-of-the-mill heart attack. The important details to look out for would be details of his or her medical history, details regarding the length of the attack and if it ends following the presentation, and evidence of recurrence. In other words, does he have these symptoms every time he gives a presentation? Does he worry about having these symptoms recurrently, etc.? While there is a strong genetic component, it can be treated with pharmacological intervention, usually SSRIs, TCAs, or benzodiazepines, as well as cognitive behavioral therapy. Patients with specific phobia have exactly what it sounds like, a fear of a very specific object or situation that the patient recognizes as excessive, but nevertheless interferes with normal function. One of the treatments that has been proven to be successful is systematic desensitization, where you slowly expose the person to those fears until they're no longer scared. Social phobias can be a type of specific phobia where patients are scared of embarrassing themselves in a social situation, for example, when going to the bathroom while they're at work. More generalized social phobias also exist, where patients are generally scared of embarrassment in most social situations. This would be referred to as social anxiety disorder. These can also be treated with SSRIs or cognitive behavioral therapy. Patients with OCD, by definition, have both obsessions and compulsions. Obsessions are recurring intrusive thoughts, feelings, or sensations that cause distress. These can be relieved in part by repetitive actions, i.e., compulsions. The key to understanding this disease is to know that it's ego-dystonic, which is a fancy way of saying that patients do not want to be experiencing these obsessions and compulsions, and they recognize that they're a problem. This is in contrast to obsessive-compulsive personality disorder, which we'll discuss later. For example, imagine a person who wants his room to be very neat, the obsession, and who relieves the distress from this obsession by cleaning endlessly, the compulsion, to make sure it remains neat. To have OCD, the person would not hold his obsession out of his own will, but rather would feel the uncomfortable compulsion to clean things. This is in contrast to a person who enjoys cleaning and does so willingly because he wants his room to be clean. The latter would be obsessive-compulsive personality disorder. Finally, another high-yield fact, OCD is often associated with Tourette's syndrome. It's usually treated with SSRIs or clomipramine, a tricyclic antidepressant. Post-traumatic stress disorder, or PTSD, refers to a persistent re-experiencing of a previous traumatic event, usually in the form of nightmares or flashbacks. It causes people to avoid anything that reminds them of the event. Such symptoms must last at least 1 month in order to be considered PTSD. If it lasts between 2 days and 1 month, it's considered an acute stress disorder. So think of a middle-aged male who accidentally kills a child while driving. If this individual developed PTSD, he may avoid driving in the town that he experienced the event in. Clinically, these patients can appear anxious and are easy to startle. The most appropriate treatments would include psychotherapy and SSRIs. Remember the mnemonic, having PTSD is hard, where hard stands for hyperarousal, avoidance, re-experience, and distress. Patients with generalized anxiety disorder show a pattern of uncontrollable anxiety that lasts at least 6 months and is not related to specific people or situations. In other words, it's not a social or specific phobia. They often anticipate impending doom, usually in the context of day-to-day events, relationships, etc. Patients often have difficulty sleeping and concentrating, and may even have GI complaints and fatigue. Typical treatments include benzodiazepines, buspirone, and SSRIs. A similar disorder is called adjustment disorder, where patients may experience anxiety or depression with impairment of day-to-day functioning following an identifiable stressor. This disorder lasts less than 6 months, except in the presence of a chronic stressor, where it can persist for longer. Malingering is an important concept to understand, especially for the wards. This term refers to a patient who consciously fakes having a disorder in order to accomplish secondary goals. Once they achieve their secondary goals, they cease their complaints. An example is a middle-aged male with lower back pain who comes in seeking opiates, but lacks the classic constellation of symptoms for lower back pain. He complains that everything hurts, and is in the worst imaginable pain, despite appearing well prior to the exam. These complaints drastically improve following a prescription of opiates. Factitious disorders are similar to malingering, except patients do not cease complaints following receipt of treatment. Usually the motivation to fake the illness is to receive medical attention. Munchausen syndrome is a chronic factitious disorder where people will fake physical signs which will cause them to be admitted to the hospital. They'll often allow various invasive tests and procedures to be performed on them. Imagine a middle-aged female who has repeated bouts of abdominal pain, diffusely tentative palpation with multiple prior endoscopies and colonoscopies that were clean, yielding no identifiable cause for her pain. A patient like this would warrant workup for possible factitious disorder. A similar syndrome is Munchausen syndrome by proxy, where caregivers will cause illnesses in a child or other dependent to be able to assume the sick role by proxy. A classic example would be a mother giving her son insulin injections to induce hypoglycemia and a medical workup. This is considered a form of abuse. Somatoform disorders are difficult to conceptualize. There are 5 different types, some of which are similar to one another and similar to concepts which you've already discussed. As a group, they're characterized by physical symptoms with no identifiable physical cause. The difference between these diseases and factitious disorder, or malingering, is that people are not consciously pretending to have these diseases. The symptoms are all unconsciously derived, and patients have little control over experiencing them. The first is somatization disorder, which refers to a wide variety of complaints which you can see here. These usually occur over a period of years. This must occur over a period of years to qualify as somatization disorder. The second is conversion disorder, where patients suddenly lose sensory or motor function, often after an acute stress. Patients know they're experiencing these symptoms, but are not concerned by them, which is referred to as la belle indifférence. Unfortunately, in real life, the indifference is not quite so belle. Anyway, an example would be a teenage girl who loses all function of her right hand after her cat dies. The third is hypochondriasis, where patients fear having a serious illness despite medical evaluation and reassurance. The fourth is body dysmorphic disorder, wherein patients have a preoccupation with a minor or imagined deficit in appearance, as shown in this painting. As a clinical entity, it can be associated with suicidal ideation, with a rate of completed suicide that is 45 times higher than the general population. In terms of Step 1 questions, look for clinical vignettes that describe a patient that repeatedly seeks plastic surgery for cosmetic issues. Avoid attempting to diagnose celebrities with this in your next issue of People magazine. You'll lose hours off your life. The final is pain disorder, where patients will have chronic pain with no physical findings. Pain is the focus of the clinical presentation, and psychological factors strongly affect the pain. Imagine a mother who gets into a car accident that fatally injures her son who is sitting in the passenger seat. The mother only sustained a mild knee injury, which caused mild pain for a few days, but then persisted in reaction to her psychological stress. Personality is a very interesting topic. Personality traits refer to enduring repetitive patterns of perceiving, relating to, and thinking about the environment and oneself. A classic example is an individual who is extroverted, that is, they're generally outgoing and are open to external stimulation. Personality disorders are very high yield for the boards and refer to inflexible and maladaptive patterns of behavior causing distress or poor functioning. People tend not to be aware of these problems. There are 3 main clusters of personality disorders that are commonly discussed, which we'll talk about next. As a mnemonic device, you can think about each of the personality disorder groups, A, B, and C, as weird, wild, and worried. Cluster A personality disorders are generally people with odd or eccentric traits, which lead to an inability to develop social relationships. There are 3 main types: paranoid, schizoid, or schizotypal. Paranoid personality disorder presents with pervasive distrust and suspiciousness. They often use projection as a defense mechanism. The second main type is schizoid, which refers to people who voluntarily withdraw from social situations, and more importantly, they're generally content with that separation. The final type is schizotypal, which often presents as individuals with eccentric appearances or odd beliefs. As stated before, the cluster A personality disorders have all the weirdness. Of these, you can remember paranoid, schizoid, and schizotypal as being accusatory, aloof, and awkward as a memory aid, as these adjectives highlight the major diagnostic features of each of the individual types. As a bonus, accusatory, aloof, and awkward are in alphabetical order, as are paranoid, schizoid, and schizotypal. This group of disorders is characterized by dramatic emotional or erratic personalities, or in other words, patients gone wild. There are 4 main types, the first of which is antisocial. This one is often confusing because it does not coincide with the conventional use of the word. People with antisocial personality disorder often get in trouble with the law. By definition, this disorder must occur after 18 years of age. Prior to that, it's referred to as conduct disorder. The second type of personality disorder is borderline personality disorder. These patients often have unstable moods as well as unstable interpersonal relationships and may even engage in self-mutilation. The defense mechanism of splitting is often used by these patients. Remember these 2 facts as they can show up in descriptions of these patients. The third type of cluster B personality disorder is histrionic personality disorder, wherein patients are often excessively emotional and excitable, sexually provocative, and attentive to their appearance. Histrionic is a word that means excessively theatrical, so look for this sort of description in a clinical vignette. Try throwing it out at bars. It impresses people. The final type of cluster B disorder is narcissistic personality disorder, which is exactly what it sounds like. Patients often have grandiose beliefs about themselves, require admiration, demand the best, and don't respond to criticism well. Think of the classical Greek myth of Narcissus, a man who fell in love with his own reflection. The final group of personality disorders can be described by the single word worried, as these patients are often anxious or fearful. There are three main types: avoidant, obsessive-compulsive, and dependent. These three can be remembered in this order as cowardly, compulsive, and clingy. The first disorder is avoidant personality disorder, wherein patients are hypersensitive to rejection and are very socially inhibited, i.e. cowardly despite their desire to form relationships. This is unlike schizoid personality disorder, discussed earlier, as those patients may be socially inhibited but often do not care to have relationships with people, so they voluntarily withdraw socially. The second type is obsessive-compulsive personality disorder. We discussed this earlier when we described obsessive-compulsive personality disorder, which is characterized by patients who have both obsessions and compulsions to help alleviate their obsessions. The main difference between these two is that in personality disorder, the patient's behavior is consistent with their actual attitude or beliefs. In other words, it's ego-syntonic. The final type is dependent personality disorder, which is characterized by submissive and clingy patients who often have low self-confidence. Let's now think about the following clinical vignette that will test your knowledge of personality disorders. A 40-year-old woman presents to a psychiatrist after a referral from her family physician due to the fact that she feels anxious all the time. Her family physician diagnosed her with generalized anxiety disorder and prescribed buspirone. However, the patient does not report feeling any better. She works as a computer programmer and spends most of her days in a private cubicle. She has no close friends and lives by herself. She says that occasionally people from work invite her out at night, but she never goes, even though she'd like to. She's not dating currently, and is worried that people won't like her. So what does this patient have? Well, most likely she has avoidant personality disorder.